validation and verification of immunoassays, high sensitive troponin, the game changer in emergency room. So here I'll share with you different cutoff for Indian female and male for high sensitive troponin I, and also within our rule in and rule out criteria for heart attack, and our KDH study for rule in and rule out criteria, how we have evolved. So this are our studies which got published. This is 2020 Univens Healthcare Excellence Award. This was in Univens, and this is published in 7 different languages, and also this is in Hindustan Times and Times of India. They highlighted our study. So this is the Univens of Healthcare Excellence Award, and so this is the main goal we have achieved. So today my talk's agenda is unmet clinical need, and high sensitive troponin I is a game changer in the emergency room when the patients are coming with chest pain. The analytical performance and clinical performance of it, and the diagnosis and prognosis use, and gender specific cutoff of high sensitive troponin I, and our study of cutoff and verification study. So why is total imprecisions, like we are talking about or listening many times, less than 10% coefficient of variation at 99th percentile? Why it is important? Because reproducibility important to derive cutoff for ruling. And why detecting more than 50% of normals above LOD is important, or limit of detection important? So to derive the cutoff for rule out. So this rule in and rule out criteria in emergency room are very crucial, because we don't want crowd at emergency room. So this criteria is for rule in, where total imprecision less than 10% coefficient of variation and 99th percentile important. And for rule out, detecting more than 50% of normals above the LOD is important. So this I have taken from Dr. Peacock's presentation. So when we discuss about cardiac troponins, high sensitive troponins or contemporary troponins, these are important. This is the cardiologist cut point is 99th percentile, and lab directors or lab diagnosis, lab physicians cutoff is either 97.5 percentile or 95 percentile. And when it is 112th percentile or 110th percentile, so we know this is the criteria where we are not concerned when the value is like more than 100 for high sensitive troponin I. But then we know this is acute MI. But when the value is in this range, then we are we need to discuss about, we need to talk about rule in and rule out criteria. And another value which is important is LOD, or lowest limit of detection. That why this is important, because based on LOD, either it can be 2 nanogram per ml. So based on LOD, we kind of rule out, we can discharge the patient. So this is very much important. And benefits of high sensitive troponin assay, because the analytical, clinical and financial, like analytical points are improved precisions, improved sensitivity, improved assay robustness, like there is less hemolysis interference, biotin interference, etc., which are of concern in immunoassays. And coming to the clinical benefits are faster decisions on discharge and admissions, more reliable and faster rule-in and rule-out decisions, like rule-in is 17.5 picogram per ml and rule-out is 2.3 picogram per ml. This depends on different instrument. There is little variation between instrument to instrument, and there are fewer unnecessary procedures and tests, so it helps in triaging the patient faster. So these are financial benefits: faster turnaround time, reducing length of stay of patients in emergency room. And so defining the high sensitive assay, this is by Predictive and Collinson, based on IFCC study. So the mandatory requirements are the total imprecisions at 99th percentile value, less than 10% CV, and the measurable concentrations below the 99th percentile should be attainable with an assay at a concentration value above the assay's limit of detection, or for at least 50% and ideally 95% for healthy individuals. So these are the mandatory requirements given by IFCC task force on clinical implications of cardiac biomarkers, or IFCC task force for high sensitive troponins. And impacted definitions and guidelines, like early definitions of MI, WHO, combination of 2 or 3 characteristics, typical symptoms, that is chest discomfort, ECG Q waves, enzyme rise, CPK, SGOT, LDH. These were the earlier criteria. So how it has evolved from 1960s, AHA, heart attack alert programs, and by daily enzymes and ECGs for 3 days. Then 2000, there is ACC, AHA, and European Society guidelines, new definition of MI, where troponin was there for new gold standard, and CKMB phased out, and total CK non-specific for acute coronary syndrome. And 2007 guidelines, revised definition of MI, recommended single marker is troponin, and they see the 99th percentile at CV of less than 10%. And for troponin single marker strategy, no more gray zone. And 2012 ACC consensus document, third universal definition of MI. And 2015 European Society says high sensitive troponin I, with use of it shortened the serial sampling assay specific cutoff. So some use 3 hours algorithm, or some European Society suggests 2-hour algorithm or 1-hour algorithm. So the gender and acute coronary syndrome, high sensitive cardiac troponin, actually there is underdiagnosis of myocardial infarction in female if we use like generalized cutoff. So, and there is underdiagnosis of MI in women if we are using generalized cutoff. So high sensitive troponin I precision allows for decreased observation time. Current European Society guidelines that says by contemporary assays or conventional assays, 6 to 8 hours serial potential, 12-hour changes over time with one value over 99th percentile. And with high sensitive troponin I assays, 2-hour or 3-hour serial testings and 99th percentiles and 1 hour also serial testings and assay specific cutoff and delta change. So these are the current European Society guidelines, and there is UKNICE guidelines where consider limit of detection for rule out, and there is gender specific cutoff, and Norway guidelines also consider the gender specific cutoff. No longer qualitative approach like positive and negative, which we used to do initially like 10 years back. And so if you see, there is shortened observation time in the emergency room, like prior generation cardiac troponin. In here, you can see like around 8 to 12 hour post event. And with contemporary conventional troponin assay, it has decreased to 6 hours, and with high sensitive assay, it is further decreased to 2 to 3 hours post event. And this 99th percentile, less than 10% CV, is very important for cardiac troponin measurement. So you can see like how it is shortened the observation time in emergency room. So negative predictive value is important for ruling out, and these are different studies like APEX study cohort, rapid rule out of acute myocardial infarction using undetectable levels of high sensitive cardiac troponin I with limit of detection. So if you see, this is in nanogram per liter. If cardiac troponin T less than 5 nanogram per liter, this is with Roche assay, then this is the limit of detection, so it rules out. But if it is Abbott assay with 1.9 or around 2 nanogram per liter is the limit of detection, with that it rules out, and the emergency physician can discharge the patient. So there are different limit of detections with different IVD manufacturer, and if limit of detection is used for ruling out with baseline 5 nanogram per liter, so myocardial infarction in 30 days 0%, and a cardiac death also 0%, and MI and cardiac death also 0% if it's used less than 5 nanogram per liter, and between 5 nanogram to 90 and the 99 centiles, MI was detected in 6 cases, like 0.4% cases, and in 30 days, and cardiac death was again 0.4%, and both MI and cardiac death around 0.8%. So ruling out with a limit of detections using 5 nanogram per liter is important. So rule out with limit of detections and 99th percentile serial measurement. So this study says that serial changes in high sensitive troponin assay and early diagnosis of myocardial infarction, and if with 3-hour algorithm, this study demonstrates, and there is a diagnostic performance of AMI of baseline and serial changes in high sensitive troponin I at 3 hours after admissions at the emergency department, and that algorithm was published in JAMA. And then there is this rule out 3 hours with negative predictive value of 2.3. Then on admissions, NPV was 100, and at 3 hours it was 99.4, at 99th percentile, like less than 17.5 nanogram per liter. So this is our KDA study at 2015. In 2015, we were using this protocol, and where we were using this, but our study, when we started using the high sensitive troponin I, so changes in chest pen protocol period between 2015 to 2018 allowed emergency clinicians faster diagnosis of acute coronary syndrome. So the waiting time decreased from 6 hours to 3 hours. So the changes made included skipping the immediate ED assessment and directly taking the patients for an ECG. If the ECG showed no new ischemic change, high sensitive troponin I was tested at 0 hours and 3 hours, skipping the 6th hour testing. And with that troponin I, high sensitive troponin I, thereby reducing the wait time and faster rule in and rule out of acute coronary syndrome. So this is ADAPT study where they have shown rule out a 2-hour algorithm, and this 2-hour algorithm a 2-hour thrombolysis in myocardial infarction score or TIMI score outperforms other risk stratification tools in patients presenting with possible acute coronary syndrome. So this is the comparison of chest pain risk stratification tools, and that study demonstrates an discharge strategy utilizing high sensitive troponin assays, and TIMI score less than equal to 1 had similar safety as previously reported, with a potential to decrease observation periods and admissions for approximately 40% patients with suspected acute coronary syndrome. So this is 2015 European Society of Cardiology guideline for management of acute coronary syndrome in patient presenting without persistent ST segment elevation. And this is the ESC guideline of 2015, and that 1-hour algorithm was published in different journals. This is the ESC 2015 guideline 1-hour recommendation. The American Journal of Medicine published it, 1-hour rule in and rule out of acute myocardial infarction using high sensitive cardiac troponin I, and they have studied in 1,811 suspected ACS patients. So this they have like if 0 hour, it is less than 5 nanogram per liter, and delta changes at 1 hour less than 2 nanogram per liter. So that is rule out or the patient discharged from emergency room, and where the NPV or negative predictive value was 99.6, and when the delta change at 1 hour was more than equal to 6 nanogram per liter, so it was ruling, and there was positive predictive value of 73.9 and specificity was 93.8. So, and there were others who were at the observational zone were 276 subjects, around 30% subjects with 13% with MI. So this is the study, and to rule out at 1 hour accurate and rapid diagnosis of myocardial infarction using a high sensitive troponin I 1-hour algorithm. So this is suggested 1-hour algorithm where high sensitive troponin I less than 6 nanogram per liter at 0 hour and 1 hour, and NPV was for NSTEMI 99.7, and at 3 hour it was 100. So this was used rule out for 1-hour algorithms. So now coming to the positive predictive value. So positive predictive value is used for ruling in, and here the receiver operating characteristic for high sensitive troponin I versus the contemporary troponin I showed these are the biomarkers of cardiac necrosis. This is in chest pain cohort. AUC for high sensitive troponin I was 0.96, and for contemporary troponin I was 0.92. And for early presenters, chest pain less than 2 hours, AUC was 0.97 for high sensitive troponin I. Area under cuff for contemporary troponin I was 0.88. So by this ROC curves, it's demonstrated that high sensitive troponin I is a better marker for chest pain cohort and also for the early presenter. So 1 hour ruling, which demonstrated that if they use 0 hour less than 5 nanogram per liter as a limit of detection, and delta change of 1 hour less than 2 nanogram per liter. So this 1 hour ruling algorithm is helpful. So what keeps clinicians up at night, or emergency clinicians? So among the patients with acute coronary syndrome, a common misdiagnosis is gastroesophageal reflux disease. So patients with acute coronary syndrome commonly describe their pain as chest pain as a burning. So 4 populations that are more likely to be discharged from emergency department with acute coronary syndrome, like female with less than 55-year-olds, non-white patient, dyspnea is the primary complaint, and patient with normal ECG. So high sensitive troponin I used to because of the atypical presentation of myocardial infarction in female. So there was underdiagnosis of MI in female, and using because contemporary assays used to have only the single cutoff. So there was lot of underdiagnosis of MI in women with contemporary assays. But with the use of high sensitive assay, there is a sex specific cutoff. So you can see with sex specific cutoffs, the diagnosis of MI in female improved. If you see, there is a generalized cutoff here, and with that you can see the female there was underdiagnosis, but with sex specific cutoff of high sensitive troponin I to diagnose MI improved the diagnosis of MI in female. So that actually 23% improve in diagnosis of MI in female in this study published in BMJ. And this is the study and clinical case. This is 55-year-old female, sharp retrosternal chest pain resolved within 30 minutes, en route to the hospital's clinical examination, and ECG was unremarkable. Smoker, but no other risk factor noted. So initial high sensitive troponin I was 9 nanogram per liter, and serial sample was 20 nanogram per liter. So diagnosis based on that was acute MI. So by serial sample of delta change, this was published at BMJ by Anup Shah et al. And this is the clinical case where there was chance of not diagnosed AMI in female because of atypical symptoms, but this was diagnosed with the help of limit of detection and serial sampling of high sensitive troponin I. So the prognostic performance of high sensitive cardiac troponin is a patient with non-ST elevation acute coronary syndrome. There is a prognostic value, and this showed prognostic performance of high sensitive troponin assay with suspected acute coronary syndrome. And There are cumulative incidents of MI or cardiac death in patients with troponin concentration less than 99 centile. So this was published in Lancet. Which algorithm to implement? There are multiple stakeholder consensus, logistic issues, current chest pain pathways, and also there are different manufacturers are telling that it can be used as a risk stratification tool in general population. Sensitivities measures a very large proportion of the general population, and there is emerging evidence to stratify cardiovascular risk for primary prevention and secondary prevention, and more specific than traditional methods. So this algorithm of high sensitive troponin I result interpretations where limit of detection was used as 2.3 nanogram per liter and of high sensitive troponin I. So this was weighing more than 6 hours. So when the limit of detections 2.3 nanogram per liter, retest of high sensitive troponin I at 1 hour, no significant change. So patient pain free, Jimmy score less than equal to 1, and other differential diagnosis excluded. So based on limit of detection, patient can be discharged. But suppose in male patients, the value of high sensitive troponin I less than equal to 19.8 nanogram per liter, and in female it's less than equal to 11 nanogram per liter, and chest pain of less than 6 hours durations, and after retest of high sensitive troponin I at 1 hour, there is no significant change, then it can be based. If the TIMI score is also less than equal to 1, patient can be discharged. But suppose the delta change is more than 5 nanogram per liter and one value of more than gender specific 99 percentile, so the patient can go for invasive management. And if the gender specific cutoff, like male more than 19.8 nanogram per liter and female 11 point more than 11.5 picogram per liter or nanogram, picogram per ml or nanogram per liter, and after retest of high sensitive troponin I at 1 hour, high sensitive troponin I, no significant change, you can work out for differential diagnosis, but there is high abnormal clinical presentations, and the values are delta change is highly suggestive of acute MI. Sorry. Then there can be invasive, again go for invasive management. So the summary is with high sensitive troponin I, there is shortened observation time, gender specific 99 percentile helps in proper diagnosis of acute MI in women, and improve the diagnosis of MI in the female patients, and it detects early presenter, and it has prognostic value. And so the gender specific reference interval in or cutoff in the of high sensitive troponin I, there is an impact of sex on prognostic value of high sensitive cardiac troponin I in the general population. This was their enhanced study, and it was the population size was 9,712, and this was published in Clinical Chemistry. So now coming to our study comprised of around 2,804 subjects, around 1,607 male and 1,134 female. Parameters studied high sensitive troponin I. We have done gender specific cutoff study in our population, and there was a verification study. So if you see the manufacturer defined cutoff at 99 percentile was 11.5, and for male it was 19.8. For overall cutoff study for healthy male and female was 17.5. And so we have seen when we use at 11.5 picogram per ml or nanogram per liter. When we use sex-specific upper cutoff for female and male, so percentage of positive female cases with acute cardiac events increased from 68% to 82%. So around 14% of total cases detected in 6 months period. So in female, so it improved the diagnosis of female patients with acute MI in the emergency room, and there is a 14% in improvement in women diagnosis using of gender-specific cutoff. So this is, again, I have taken from Dr. Peacock's presentation. So like some crappy troponin I assays, there was only 9.8% discharge in, and with high sensitive troponin I, there was 38% discharge, and they have discharged 28 more in one day. And this was 100 patient study, and this is the same thing what we have observed, that average length of stay in A&E was 43% less with high sensitive troponin I based chest pain protocol as compared to the conventional troponin I based protocol. So the average A&E or ER length of stay is 7 hours and 4 hours for contemporary troponin I and high sensitive troponin I based protocols respectively. So if you see, there is 3 hours improvement in length of stay, and time effective testing protocol has better acceptance by patients as well as ED physicians. So since a majority of patients in our hospitals are pay from pocket, so their acceptance and hence compliance of high sensitive troponin I based chest pain protocol, it has markedly improved the patient satisfaction and compliance. So now this is our verification study. So as we know, NABL and College of American Pathologists and also ISO 15189, they suggest that we should verify our parameters. So we have verified the analytical accuracy of high sensitive troponin I when we have started. This is our verification protocol, and 20 samples within the testing range by both a new method and comparative methods. And then we verify the precisions, we verify the reference interval, and verify the analytical measurement range and clinical reportable range. And now it is called as EMI or extended measuring interval. So suppose we are going to our vacation flight, which pilot we will choose? Of course, we want to land on the runway, and we don't want this pilots. We don't want so much variation. We want our process should be near the target. So this is called accuracy. So accuracy is the agreement between the test result and true result, and the bias is a measure of trueness, and this is by comparison of new method and reference method. And CLSI EP9 says analyze minimum 40 samples, but EP15 says 20 samples in the analytical measurement range we can analyze, and that should be in AMR, and then we can plot the bias plot. And this is our study in 40 samples. So as R value is 0.991, we say that this is verified. And this again, precision is the closeness of agreement between independent test results obtained under stipulated conditions. So it's expressed quantitatively in terms of imprecisions like standard deviation, coefficient of variations of the set of replicates. So there are two types of precision claims: repeatability within run precisions and within lab precisions. So this is our precision study. So usually 5 runs for 5 days, that is 25 replicates in all 5 days of different level of samples. And also EP5 to say a minimum of 20 operating days are recommended for precision study. Then I have described the reference interval study, and we already discussed with you the 99 percentile or sex specific reference interval, which we have derived in our patients. And this is lean Six Sigma in turnaround time. This was done in around 6,167 male and female patients between 2014 to 2016. And now also we are continuing this monitoring, and we applied the define, analyze, measure, improved and control DMAC principle. And we saw the bottleneck points and non-value-added steps, and we tried to improve our turnaround time. So when we started, our sigma value was 3.14, but in 2016 it was 4.75, and it has improved now more. And with GMAC principle and lean and sigma implementations, the turnaround time of high sensitive troponin ISA improved from 38.2 minutes to 32.6 minutes. And there was 1 point sigma improvement of quality, 3.14 sigma to 4.75 sigma. And that is a actually very measurable improvement in terms of sigma in turnaround time, and 15% improvement of that compliance. Like when we started in 2014, we were at around 74.7% compliance, and now we are at 99.3% compliance. So this is how our turnaround time improved from 38.2 minutes to 32.6 minutes. And this is our sigma rating and compliance. If you see, in August 2014 it was 74.7% compliance. In November 2016 it was 99.3%, and sigma rating improved from 3.14 sigma to 4.75 sigma. So what we have really learned, that high sensitive troponin I gender specific cutoff, and now we have started the risk high sensitive troponin I as a risk stratification tool, and in acute setting, also in non-acute and in general populations, but that study at very initial stage.